this computer, and I want to welcome Kathy Sue Dory. And I need to tell you something special about her work and her doctoral studies. On March 12th, Kathy Sue became Dr. Dory because she defended successfully her dissertation. That's a big deal. So I thank you for that. Thank you for your hard work. And just want to say a little bit about Kathy Sue. Kathy Sue went through our Masters of Creativity. You can see all of her credentials there. But I want to tell you, she was on a mission and she had a vision and she did these amazing things towards helping. And this culmination of it is just something that, as you, when you see somebody who has that creative characteristic of persistence and passion, and you see it come forward into a doctorate and defend your doctorate, for me, it's just so exciting to connect with you again and to see where you're at with your work. So thank you, Kathy Sue.
Thank you so much. Um, okay. Okay. I figured out how to advance it. So sorry. So I did my dissertation on trauma bonding in sex trafficked women. It was a single subject, multiple baseline mixed methods study. And this is just what I'm going to be talking about, some of these things. And it looks copy heavy. And if I'm going to try to save about 5 minutes or more, if possible, for any questions or comments. But basically, I want to talk about the problem and purpose of the study, the research method, some of the theoretical frameworks I use, which should look very familiar to you all. Three of the four research questions, the debriefing feedback tool by Dr. Knoller, the treatment plan and how I developed it. I want to introduce you to the two participants who went through the study, and I do have written permission to use their pseudonames and their photographs. And if we have time, some new insights and implications, and of course, maybe some questions. So the problem with and purpose of this study, the problem is that when it comes to trauma bonding, there is no standardized definition for it. There's no diagnosable disorder for it. There's no test for it to identify and diagnose it. And there's no standardized treatment protocol for it. There's a lot of things out there, but there's nothing that's been kind of comprehensively created, developed, and studied, and especially for and checking for its efficacy on some of these things. The purpose of the study was to look at the relationship between the trans-theoretical treatment program that I developed and four of the five dependent variables. And those were trauma bonding, the ESI framework of EQ, creative problem solving, and the creative environment. So the research method I used was a single subject, like I said, and that just means that it was small, meaning the participants. You can do one of these with one person, but I had two. And multiple baseline just means that I had several variables. Those are those dependent variables I just talked about. Also, there's three phases to this type of design. There's the baseline phase, where you gather all your data to see where your participants start from. Then you handle the treatment program. And then the final phase is like a post-treatment program phase. There were 7 data points over a 4-month intervention. That means I collected this data 7 different times. I did quantitative and qualitative data. And mixed methods just means that you collect this data separately and then you merge it and interpret it to gain some insights. I also did some qualitative session data in phase B, and then I merged that with also the quantitative and qualitative instrumentation data. So basically, this type of design is very heavy with a lot of data gathered. Now, to be a part of the program, treatment program, they had to be biologically sex trafficked females. They had to be diagnosed with trauma bonding. They didn't have to be sex trafficked for any minimum or maximum duration. They had to be English speaking. They had to be at a minimum fourth grade level because of the materials that I was preparing. And I didn't have the advantage of having like a translator or someone with me so I could add anybody with different languages. So I had to keep it to English speaking. They had to be 18 years of age and up, and they also had to be willing to learn ESI and CPS skills. So these theoretical frameworks should look pretty familiar to you. And this is really what I based my research study on. And so when I was teaching, EQ skills, it was founded on the psychological well-being and positive mental health. CPS skills obviously was founded in our theoretical framework of problem solving and CPS. And then the treatment program was really founded on the trans theoretical model and accelerated learning, as well as the creative environment, the principles and the strategies that we use. And the trans theoretical model, the reason I use it is because there is no diagnosable mental health disorder for trauma bonding, and that is highly recommended. That is the type of treatment program you want to conduct when you don't really know what you've got. This looks like a lot. I'm not going to go through it, but I just wanted to show you the type of matrix that's involved with a mixed methods study. And research question one really had to do with how does EQ influence or predict trauma bonding when it's taught in a trans theoretical treatment program. And the instrumentation that I used, quantitative, was the EQI, which I'm sure that you should all be familiar with. The trauma bonding rate of prevalence assessment, which is a quantitative test that I actually had to develop and create for this specific study. And then I had to create the qualitative counterpart of the EQI. Research question two had to do with creative problem solving and how to learning creative problem solving skills affect the trauma bonding that is experienced in female sex trafficked victims. The quantitative instrumentation for that is I just took the EQI problem solving subscale. I used that, again, trauma bonding rate of prevalence assessment, and then I did the counterpart of the quantitative portion and created some questions on the problem that relate to the problem solving subscale. Question four, that's not a typo. I had a third question, but because of the time constraints today, I did not involve it. And I really wanted to focus and hone in on the applied creativity aspect of my research. So question four had to do with, what happens when you conduct a treatment program and you use the creative environment principles and practices? How does that affect trauma bonding? And to test that, I used the person environment fit scale for creativity. And then, of course, had to create the qualitative counterpart to that. And also, I used the trauma bonding rate of prevalence assessment. You should see and be very familiar with Dr. Knoller here. She created the debriefing feedback tool many years back. I have been using this feedback tool for over 15 years, actually. And it was just a normal thing. Of course, I was going to use it and incorporate it into my treatment program. So I'm not going to go too much more than that because you should be very familiar with this tool. But what I will say about this is that in the 15 years that I've been using this, there has not been one person who had been allowed to speak like this at the end of a session. And especially when you're working with trauma, people who have experienced a lot of trauma, they love this. They love that they can actually share what they thought about the session. This is the way I developed my treatment program. I took an APA standardized treatment plan approach, and then I incorporated applied creativity into it. And there was a 7-step process. The first, of course, and this should seem real familiar. We have to identify or select the problem. My problem was trauma bonding, right? And trauma bonding happens in many different dysfunctional relationship environments, like sex and human trafficking, intimate partner violence, domestic violence, kidnapping, and so on. This is a definition that I had to actually create, and I've been using this definition in the field for over 10 years now. It does not mean that it's been standardized. It hasn't been. You can see that there are 3 different citations here. And by the way, if you want any of the citations or the references that I use in here, just give me a holler and I'll be glad to share them with you. Um, so basically, if I had to, in layman's terms, I use this quote down below, and it says, "As a little girl, we are scared of the monsters under our bed. As we grow, we fail to recognize the very monsters we bring into our bed." And when I say that to my clients, there's an immediate aha moment, like, yeah, that's what I've been doing. Next, I had to define the problem. And this is our process of clarifying the data, gathering the data, that sort of thing in regards to CPS. But I had to define it. So I used my CPS process on this. And I've been researching this for many years. And these are the symptoms of trauma bonding specific to sex trafficking. So I'd take a symptom, I'd throw it on a post-it note, and then I would just look at that, then I would cluster them. And what I found was that there's the emerging themes of trauma bonding are these six constructs: the cognitive, emotional, social, physical, spiritual, societal, and financial. After I had that, I then thought about, well, what are the predictors? What's going to break these symptoms or reduce them? And so back into the research, I went again, the same process with every predictor. I put on a post-it note, I threw it on a flip chart, looked at it, and I found that the themes were consistent. They were the same. And so then I had to put the treatment plan together. And this is a standard treatment program plan from the APA. And so you have goals and then you have outcomes to resolve the problem, right? So this is I added some creativity into this, the applied creativity. So you see, I have the creative environment. It was very important to establish the setting for my clients moving forward. And then, of course, the modes of structure. These are things that every creative facilitator uses. We welcome, we do housekeeping, share backs, we share the agenda, and so on and so forth. And then the goals are, you can see, are the actual constructs of trauma bonding, and then the research questions that are associated with each of those constructs. And then if you look at the objectives, the 1 through 18 objectives, those are the predictors. So that's how I created my treatment plan. From there, you have to create an intervention, right? What are you going to do? What are you going to teach out? So I had 7 sessions in phase B, 1 session in phase C. So I'm not going to go through all this, but just this gives you an idea of the type of things that I taught over these sessions. Took me about 416 hours, and it's really important for people to know the time that's involved with all of this. I spent about 171 hours with Mary, 145 with Elizabeth, and the overall development of this took about 100 hours. And the actual research cost of this was $6,600 out of pocket. And if you put in my time at just $50 an hour, you're looking at over $27,000 for this research study. Then I had to diagnose. I had to make sure these ladies were actually trauma bonded. And so I created the trauma bonding rate of prevalence assessment. And this, again, you can see is according to the 6 constructs. And the questions that I asked had to do with the symptoms. And that was the quantitative portion. The qualitative portion of this, in order to make it a true mixed method study, included the biopsychosocial spiritual assessment, the BPSS. And the reason I use the mixed methods is because it's quantitatively driven, but the qualitative portion, instrumentation, is there to collaborate what I find in the quantitative data results. So continuing with the trauma bonding, it's same thing. You collect, you analyze, you merge. And what I did find out is that both ladies did meet and were positive for trauma bonding. And this is just a chart, a display in a mixed methods way of gathering and comparing the quantitative and qualitative data. This is Mary. Wonderful, wonderful woman. She is 70 years old as of time of the study. She obtained her GED at the age of 65. She was sex trafficked from infant to 35 years of age. And she met most of the symptoms of being trauma bonded. However, there were a couple of instances that she did not necessarily have a symptom, such as she was never a runaway or part of the foster care or juvie system. She was kidnapped twice and escaped twice. And I gave foresight. I administered foresight on both women because it was important for me to know how do they learn, what are their preference styles. And Mary was an integrator, and I'm an integrator too. So I knew that every time I met her at a session, I had to be ready. She was going to push and just she was going to, push the boundaries every single session, and she surely did. This is Elizabeth. She was 50 years old at the time. And one of the things I didn't mention in regards to the treatment program, I spent a little bit more time on Mary than I did with Elizabeth because Elizabeth did not finish phase C. And Mary had a lot to say, and they had a 20-year age difference. So it just made sense to me that Mary would have more to say than Elizabeth. Elizabeth was sex trafficked for 1.5 years at a much later age than most people may think. But as we spoke, we realized that she was also really sex trafficked. She was used as a personal sex slave for an intimate partner from the ages of 13 to 17. She too was never a runaway or part of the foster care system. She actually scored as an ideator on Foresight, which is really amazing because both women had experienced over 10 concussions, and Elizabeth actually has a traumatic brain injury. So I find it just kind of interesting, and I have to really maybe do some further research on that. And as her being an ideator on Foresight. I conducted the intervention, that's step 6, and these are just some of my notes. I always had an agenda on a flip chart, but I also had this for myself. Every session was videotaped, audio taped, audio recorded, and then I transcribed each one of those sessions. And the average length of those sessions could have been anywhere from, 3 to 6 to 7 hours. Some of the things that I used, I wanted to share some of my facilitative materials with you so you could see what I did and how I incorporated applied creativity. And so you can see that I use the agenda, my modes of structure with some of these things. And one of the interesting things was, and we always ask about learning outcomes, right? What are their takeaways when we're dealing with the client? And I wanted to see what their learning outcomes were, of course. What I found was fascinating. Their learning outcomes aligned with the symptoms and that they were experiencing and the predictors. They knew what was wrong with them. They knew what they needed to work on. And it was just a fascinating experience to see that. Some of the skills that I taught that were related to the EQI in order to decrease time trauma bonding included a couple of exercises that I've created over the years. One is the Your Belief System. Another is the Trust Circle with criteria. And I teach them about the importance of mistakes, positive affirmations, their word choice. I also gave them a test on growth versus fixed mindset. And interestingly enough, they both had a growth mindset. They were trauma bonded and yet had a growth mindset. So you could almost see their struggle to break out of the jail or the cell that they were in. And up here also you see the evaluation matrix that I used with Elizabeth because she was actually evicted and she needed to find a new place to stay. Some skill-based activities I did because I wanted to see whether a positive environment correlated to a more positive person. Now, I know that this is true. However, we need tangible results to actually show the efficacy of this. So that is what I tried to do here, right? So I looked at self-regard, self-actualization, optimism, and their happiness well-being indicator on the EQI. I did self-regard exercises. You can see the cartoon storyboard that many of us have used and will use in the future. They absolutely loved this because if you know what, these ladies had a lot of despair, but their level of hope for their future far outweighed. And when they did the cartoon storyboard, they were like, yes, they felt justified, or they could see where they were going. It was very, very impactful for them. The Chase Your Happy looks like nothing up here, but let me tell you, it was amazing because I've done this exercise for years. And I did this with Mary, and I wrote, Chase Your Happy, here we go. And she says to me, Kathy Sue, cross off that word chase. And you put fight for your, because I don't chase my happy, I fight for it. And I said, oh my goodness, of course you do. And I did that. And then we finished the exercise. And when we were done, I wanted her to know that that was an amazing thing that she did, because what she had done right there was to challenge the process. And everyone knows about the leadership challenge and all of the practices involved with that. But I didn't even teach it. I don't even have to teach it because it just organically is taught and learned. And so I told Mary, this is wonderful. You challenged the process here. You told me no. And that just built and increased her autonomy and strengthened her as a leader. I'm not going to go through all these. I just had to show you this. This is the CPS process from start to finish for Elizabeth. Now, remember, Elizabeth has a TBI. She's been told all her life that she can't focus. She is actually bipolar schizophrenic. She has two voices in her head that never leave her. They started when she was 8. She has 29 suicide attempts, one while I was with her. And this is all the work that she has done. Look at it. It's just amazing to me. And you'd probably think, how many sessions did that take? And let me tell you, it wasn't sessions, it was hours. This whole process for Elizabeth took about 4 hours. So that proved to her that, hey, I guess I can focus. I guess my mind isn't as bad as they say it is. And I can finish something that I start. So it was very just, she just, I don't, it was just a wonderful, wonderful experience to see. This, as in 2013, I received this award from the Dr. Murdoch Award. And this is something that I've held close to my heart for ever since. And every person who goes through a treatment program with me is presented with the same book with one of my inscriptions. And both of these ladies got one. The last step is to check on your efficacy of this intervention. Did it work? If it didn't, why? So with Mary, I had 100% treatment efficacy on the overall trauma bonding, EQI, and the problem solving subscale. I had questionable treatment on the PEFSC. Now, you can look at that, but look at the numbers. Mary went down 84 points in trauma bonding, increased her EQI by 50 points, increased her problem solving by 67 points, and increased her PFSC, if you combine both subscales, by 8 points. This was amazing. This was a 3-month treatment program. You can imagine what could be done, because usually I teach and do this for a year. And I truly believe that the creative environment and being tested by the PEFSC would be better. It would give you better efficacy if you elongate the program. But that's something I have to research in the future. Elizabeth had the same type of results, and she decreased her trauma bonding by 67 points, increased EQI by 21, and increased her problem solving by 26 points. She too had just a very low increase on the PEFSC, but still, she had fabulous results. I just want to say that I did all the qualitative instrumentation, of course, and it all corroborated what the quantitative results showed. And I just want to show these quickly, just to give you a visual on how EQI correlated. And EQI did seem to correlate and affect trauma bonding. And what that means is as their EQI score went up or down, trauma bonding either went down or up on both of the women. Problem-solving subscale was a bit inconclusive, and that's because it seemed to correlate for Elizabeth, but didn't necessarily correlate to Mary. And again, we just need to research this more. because this is really, really important because we need to put tangible results on this problem solving because that's what we teach and we need to capture it. We need to have tangible results. And I truly believe that the EQI problem solving subscale is one way to do it. The PEFSC was also inconclusive, like I said, but if you see here, you see these yellow lines going across. And when you do a single subject research study, that's my baseline. And basically, you want to either fall under or fall above. And if you look at that, you can see that in Mary, she actually fell below in trauma bonding, even though she increased in the phase C. And then she fell slightly below it. And then above it. But, and then you go to Elizabeth and you can see that too. And that's how you visually tell whether your program worked or not. I took it a step further, but that gets into a little bit more detail that we just don't have time for. Some of the new insights is that I found an emerging dysfunctional relationship, and it wasn't human trafficking or anything like that. It wasn't a person to person relationship. It was actually a person and a societal system. The actual societal systems are actually the perpetrator. This is who some of these women are actually trauma bonded to. This is very exciting and emerging. And this is something that also really parallels to the creative environment or the environment and the person in the environment. And that's why we need a lot more research when it comes to this. Some of the implications really is that I'm going to standardize trauma bonding as a whole comprehensively. Some of the implications when it comes to creativity, the creative environment was introduced in the trans theoretical treatment program to encourage positive behavioral development that can break generational cycles of abuse. And this was being introduced in the mental health professions. The EQI, as well as the EQI problem solving subscale, is being introduced. Finally, as in the mental health professions. Dr. Ruben Baran, he created the Baran EQ before MHS actually bought it in 2011 and called it and renamed it the EQI 2.0. But Dr. Baran created the EQ for specific to mental health professions to help us help people. So it's very exciting for me to be able to actually have this incorporated in my study because there's no other studies really who have done what I have done. And CPS and the PFSC has been introduced into the mental health professions. And it's just, again, very, very exciting. And I really hope that what I've introduced here is the significance of using applied creativity in the mental health professions. And that is it. So I'll take any questions or comments, and I believe Sue is moderating that.
Yes, we have a question in there. Let's see if I can put myself, let's see if this is the right one. Oh, no, wrong one. Okay. So question is, to what extent does personality impact this intervention?
Oh, it impacts it a lot. It's one of the reasons why I did foresight number one. And also with all the instrumentation, when you do quantitative instrumentation, it's pretty quick. Sometimes people do it without anybody else. But when you do qualitative, you can ask those questions and you can then start to have a feel for this person. And what is their personality like? How do they experience learning? What do they think? So it plays a great deal because you cannot ever take a cookie cutter approach and you have to get to know the person you are working with. So it takes it's a huge part of it.
Excellent. Excellent. Well, what I find so interesting is your use of creative problem solving and the use of so many of the concepts in creativity. How is that received by those in your academic circles?
Well, I'll tell you, Some people think it's kind of fascinating, and other people, the mental health professions is very, I don't want to use the word conservative, but they think within a box. Let's put it that way. Um, so sometimes it was accepted and sometimes it was questioned. I have never been stopped from doing what I do, but sometimes it was questioned, and other times it might have been poo-pooed type of thing.
Mm.
Yeah, but I'll tell you, my clients and who I work with, and these two participants, they couldn't get enough of it. The fact that they were facilitative materials and they stuck on their walls. These women had their house filled with their work and it was stuck on their walls. I wanted to take it home. They said, yeah, absolutely not. I need this. I want to see it. I need to see it day in and day out. And for Elizabeth, it was very, very important because of her TBI. She couldn't retain information. And so she didn't have to worry. I took the stress and the anxiety of having to remember out of it. And so she just was like, I can just look at my flip charts when I'm doing this. And the other thing with seeing it and being visual with all the flip charts is, that's why, and that's how Elizabeth literally um, realized how trauma bonded she actually was. We did a visual flip chart, and I didn't share it because there's a lot of personal names on it, and I couldn't do it for confidentiality reasons. But the visual that I used, it took her, she was just so taken aback. And a week later, 1 week later, she was done with him. And she said the visuals were just that impactful on her.
Wow.
So creativity is very, very important in the mental health professions.
Yes, we have a couple other questions here. Thank you. That it's just amazing. I mean, the two women, to think of all they've gone through and just how helpful that was, uh,
Hmm.
is very inspiring. So, Jennifer asks, is there a point in the process where you believe the CPS training might be absorbed more effectively? And does it need to be repeated over time for further progress?
The latter part, does it need to be repeated? I think it just needs to be practiced. It might be semantics that we're talking about, but they need to practice it, and they also need to practice it in their daily lives. And the first part of that question was, is there a point in the process when, what was that?
Yeah. Jennifer, you want to ask it?
Sure, sure. Thank you so much. I was just wondering if there's a point in the process where you believe the CPS training might be more readily absorbed. Like if there's sort of some of that early, and
Mhm.
this is my ignorance speaking, I don't know
Mhm.
EQI well, but is there some sort of that early work that needs to be done for them to kind of baseline or open up before they can start receiving in more of the tools?
It starts from the get-go, literally from baseline. It starts from the get-go. Once they are able to share their voice, they are ready to receive. They know that they're in a safe environment, they are ready to receive. They are constantly learning and retaining. And the key is to put it into practice. And then the key is to stay with them. Because, and one of the questions I had from my dissertation chair was, how do you see, do you think this should work better like in a containment, like in a shelter where they're not going outside and stuff like that? And I said, absolutely not. They need to put this into practice, into everyday life, everyday challenges and everything. The more challenges you have, the more you can come back and talk about it, and you can start practicing all these other tools. And the beauty of applied creativity is I can't tell you how many tools I've created on the fly, because that's what you do. You have that open mind. And if there isn't a tool available, what do? We create it. And I've created things on the fly. So these ladies and all the other trauma patients I've worked with in the past are ready to receive from the get-go.
And we have another question. Is there a new workflow you would recommend following your findings? Absorb concepts in a specific order, perhaps, or give different phases more time?
The way I created the treatment program, and I conduct the intervention, there is a I use a protocol. There are the same things that I use in the beginning, which was on I don't know if I can go back. Oh, maybe not. Oh, sorry.
Yeah, you can click on it. If you keep it there, go ahead and click on the one you want.
Okay. All right. So if you look at the treatment program that I did, where is it? I don't know where it is. I don't know where it is. Oh, here it is. Okay, so I always do start with my learning objectives. I always introduce the importance of mistakes, and playfulness and dreaming. And so these are things that I automatically always do. Like they're standard. Within the first two sessions, those are taken care of. However, and then I have it all built, but the beautiful thing about creative problem solving is that it's flexible and adaptive. And as long as and so sometimes I have to stray from the agenda. Now, on this particular study, I could not stray from what I wanted because I was testing measures. But normally, I mean, I did a little bit, but I had to hit all the marks in order to be able to test all those dependent variables. So yes, there is a certain process and a structure to it, but at the same time, you have to be able to adapt and be flexible to what your client or one of these participants needed. And that did happen. I mean, I actually had to do a exposure therapy on the fly in the car driving because she was literally suicidal. And so that did deter. Actually, both of my participants had something happen. And within 2 days, I was traveling and doing the same thing with both of them. So that did kind of deter from what was on the agenda. So that's but I had to bring them back. I had to get them back to the program to finish it. And Elizabeth also was in a full-blown manic episode, so that was also handled. I hope that answers your question. I'm not sure.
Yeah, it's so I have one final question for you. And that is, those of us in the session today probably, and I don't know, all our participants here often probably work with different types of clients.
Mhm.
Obviously, I don't have that kind of training that you have. And so, my question is, what can we take away from this for all the wide variety of people we work with?
That creative problem solving needs to extend out. It was created for world challenges, and and it's not used in the mental health professions enough. And it's not used, it needs to be used in the high schools, all the schools, all of the schools from kindergarten or even preschool on up. Um, People need to know that they're not trapped and that there is a way out. And it's called creative problem solving. And in the mental health field, it is truly, truly direly needed. And I was also asked, how do you see this moving forward? Like, are you going to do this? Like, can you teach it? And I said, well, I can. And he says, like, well, who else, are you going to have help or whatever? And I didn't say this to my committee. But in my mind, I thought to myself, the only person who else could do this, another creative, because they understand, they have the mind that they could do this. Now, maybe, they would have to get educated in the trauma field, but they could do something like this. And so it was kind of pretty interesting. I said, you might, if you can't train an organization like a human trafficking organization, you can go in and train them to do something like this. And if they're not comfortable, guess what they need? They need a creative to come in and help.
Mhm.
So I think sometimes our creative field is in a box and we kind of position ourselves here. And we need to extend out. Everyone, every profession, not just on the corporate level, needs help and needs to know how to do this. That's what I hope to impart on with this research study and its importance because it saved me. It's why I am who I am and what I do. It is because of that master's program. This trauma bonding study is a reflection of me. And that's how far I've actually grown. And it's because of creative problem solving. And so, I think it just needs to be shared and utilized and facilitated more.
Well, that's actually very, very inspiring. And I can see you really sharing this message. And we thank you for doing that at this session today, because I think that's part of it. This is so fresh because it's just been finished. And I remember finishing my dissertation, and the first thing I did was present. I wanted
Mhm.
people to know about it. And I really thank you so much for coming to the CEE conference to do this. And look forward to your continued work on this area. So thank you, Kathy Sue.
Thank you. And thank everyone who came and listened and shared it with me. Thank you.
Yeah, and Jennifer says one of the most profound things I heard you say was there an emerging dysfunctional
Mhm.
relationship between the participants and the societal system that becomes the perpetrator.
Mhm.
This is so key and so true in so many situations
Mhm.
and for so many people.
Yes.
And you have a bunch of thank yous in the chat as well. So thank you very much.
Thank you.
Let's see if there's any last questions. I'm going to turn off the recording.
Go ahead.